So I think we have to pass to the other speaker. Now, Ender Ofluoğlu is going to talk about the implant failure. We're going to, I think, discuss about a case.
Hi again. I would like to present my case about post-junctional kyphosis, about the implant failure. My case is a 64-year-old female. She has a low back pain. It's the main complaints of her. Also pain in both legs, more on the left side. And she has a walking difficulty. She's talking about this. When I start to walk, I feel my legs in the knob and weak. And her neurological examination, she has a neurological education to 20 meters. And some weakness of the leg, left leg and dorsiflexion too, loss of 2 point and extension hallucis longus, loss of 3 point. And you can see the MRI. We have a lot of spinal stenosis, multi-level spinal stenosis, especially in 2, 3, 4, and 4, 5 levels, 4, 5 levels. And also there is a compression of the left side of the L5 S1 extraforaminal compression and L5 compression, you can see. And there is a scoliosis X-ray, AP and lateral. She has a negative sagittal imbalance. Also, her pelvic parameter is damaged, not normal. You can see the extension and flexion radiogram, and you can see the thoracolumbar junction, kyphotic thoracolumbar junction inflection X-ray. So we decide, and the her CT scan. Not usually we use it, but we use why. There is some osteophytic changes you can see. Always the adult patients, we have to look the bone quality, and DEXA or QCT is more better than the DEXA, I think. She has an osteopenia, especially in the spinal column. We decide to make a correct sagittal balance and coronal balance. It's a correction, deformity correction surgery, but not only deformity correction surgery. We decompressed neural compress areas, and also always we use the L5 S1 interbody fusion when we pass the ilium. It's good, I think. After 3 months, a small low energy accident in the home accident. She has a complaint of the paraparesia after 3 months. You can see the compression of the UIV, upper instrumental vertebrae, and screws pull out, and breakage of the lateral wall of the vertebra. We take the patient the second surgery. We go to level up and connect the rods with the rod connectors. After then, she's okay. She's healing in the 1 year. After 1 year, she's okay. The second year, you can see the second PGK. after the 1 year of the surgery, the second surgery, but it's not symptomatic. We don't touch it. And the third year, the second year follow-up, you can see the rod breakage, not connection area, the upper of the connection area, but still she is not symptomatic, and we are following the patient. We don't touch it. Thank you.
Ender abi, thank you so much. So you turned as the first surgery. So we have started it.
Yes,
Surgery
beginning
at
of
the
the
end.
surgery we turned it, but she has no complaint.
Yeah. So
She's
these kind of surgeries are difficult surgeries, especially the adult degenerative scoliosis cases.
Yeah.
We have to talk with the patient very good before the surgery that you're going to have 40% revision surgeries. You have done good surgery. Your sagittal balance after the first surgery is very good, but the patient has to know that 40% you will need a revision surgery from the proximal or maybe from the distal or from the rod breakage. So Said Naderi has given a good example, and we have Richard Asaker as a guest in Istanbul Spine Masters last time. So we all deformity surgeons as spine surgeons. Someone is creating the deformity, someone is solving the deformity, and someone are ignoring the deformity. So any question, any comments about Ender Ofluoğlu's case?
I'll make a comment. This case is a perfect example of the fact that there is no real thoracolumbar junction.
Yeah.
There is a thoracolumbar region. And if you look on the X-ray on the left here, you could almost argue that this should have been taken up to T2 or T3. But this is all easy to pontificate on in retrospect.
Yeah.
And so I don't do this surgery, but I criticize it. And I think this has still been a great job. And you did what the vast majority of accomplished deformity surgeons would do. And this is what they face. I think the comment was made that 40% of these need to be revised. That is a great illustration of the complexities of this region, not junction, region.
Yes, you're right.
I can comment on this.
Yes, please.
Actually, I wouldn't do such a long fixation for such a patient because although she had back pain and neurogenic claudication, I would focus more on neurogenic claudication, good decompression, and probably 1 or 2 level interbody fusion in the L3 or L3-4 or L4-5, and a shorter fixation.
Mehmet, did she need fixation and fusion at all?
Yeah. Actually, one point here is that although the patient has already a hyperlordotic curve before surgery, but keeping it too lordotic is one of the reasons of PJK. So you could have tried to correct the lordosis a bit.
Sir, how can you prevent the post-junction kyphosis with the short fixation? How can you prevent?
I think the possibility of PJK is very related with the level of fixations. If it is
Yeah.
too long, it is more prone. It's more
If you
likely.
stop the lumbar area, you can see the PGK. Yeah. No, short fixation is not solved, I think.
So what would I do? I will do the surgery like at Ofluoğlu, but the patient has to know that he's going to come back.
Yeah.
From the proximal or from the distal. So if the patient accepts it, so long fixation will give you more complication. But if you want to correct the deformity, you have to do it like a surgery from T10 to ilium.
I think
So
She's
Haluk
lucky.
has a comment on that. Haluk, you can.
Haluk
He
wants to
says
go
that
to the pre-op
we have to
X-ray.
go to the beginning.
Yeah.
Go back. Peter. Go back to the first slides. Good. Okay.
Yeah,
Stop.
that one, yes. Well, as I see from here, yes, the patient has a deformity in the lumbar area, but sagittally, well balanced. And the primary complaint is about the neurological symptoms and the pain. So as Mehmet, I would focus on more to the direct complaints and the obvious reasons for the neurological signs and symptoms. And if you go back to the X-rays images, to the reconstruction of the X-rays, we see some lateral and subluxations in the next slide. I guess was the X-ray, not that one. This shows that the thoracic area is mobile.
Well,
Yeah, this one. So if you really do the instrumentation, then you will go up maybe up to T2, not at the T10 level. T10 level was not the level that I would stop if I do the instrumentation. But here, I would focus on two levels. Do the minor decompression, no instrumentation at all, leave and observe the patient.
won't you stabilize it, Halukberg?
No,
L4, L5,
because
L5, S1.
because this is the disc is already nearly flat. You see that the nature has already made the maximum effort to stabilize itself by having the osteophytes around. And if you really start instrumenting, then you need to instrument all spine, not because correcting the deformity, but to stabilize that you create the instabilities iatrogenically. So to me, single-sided double decompression would be really an option for this case.
So you'll do just decompression. Am I right? Okay,
yes.
This is an option.
Alex makes a great point. She's already stabilizing herself, number one. And number two, the less you do, the easier it is to do a revision surgery.
Of
if
course.
you've done a lot of surgery, then revisions become increasingly complex.
So Yahya was going to say something. Yahya, you can open your microphone.
Yes, I asked to the Professor Benzer because maybe we should think different strategy for elderly patients because maybe the biomechanical rules different. For example, for this patient, there is a fusion area. Maybe only the cooperation is enough for this patient because the sagittal balance isn't very bad. Maybe only the compression helped us prevent some complications. And because of that, I wanted to ask to Professor Benzer, what do you think biomechanic rules for elderly patients if postoperative sagittal and coronal balance target is according to normally SVA, can it lead extra force to spine and lead to extra complication? Should we think different strategies for elderly patients?
I would think the same. You know, I mean, I think we can be a little bit more lenient with aggressiveness simply because of the risk associated with that in an elderly patient. But you know, the parameters are the parameters. I think we need to follow the rules as best we can.
Thank you.
So I think we have a good discussion. Any comments or any questions to Benzel, Sait Nederi, or Ender Ofluoğlu? Zilali, would you add something? So I'd like
And
to.
then, can you unshare your screen?
Okay.
Can you unshare your screen, Ender?
I'm trying, sir.
Unshare.
Okay.
At the top of the screen,
You will.
you go to the top, it should be unshare.
No, no. Do not share.
So that- yeah.
Good, good. This is fine. Actually, it was really a good discussion, and we learned again that without a good biomechanical knowledge, we cannot understand and solve some problems, especially in deformity surgery, but also in other surgeries. Do you want to add something, Ed Benza?
No, I think this is a great discussion. We've covered the gamut of biomechanics and applied biomechanics. And we should all come away from this with an increased understanding of the complex situations we deal with on a daily basis.
Yes. I think we can finish this webinar here. And I thank all the speakers, especially Ed Benzel, and all the participants for being with us for this evening. I wish to see you again in future meetings.
Okay. Bye,
Goodbye.
everybody.